Hello, in this video I shall share with you some important points when you have to perform the transurethral resection of the prostate and the patient is having a prostatic abscess. You may call that as TURP for prostatic abscess. I will specifically try and highlight to you those points where the technique of resection is slightly different from what is standard. Now let me first of all elaborate to you when actually is the transurethral resection indicated. Commonly you have small peripheral abscesses that you can see on transrectal ultrasound or even on a CT scan, a small abscess. When you have a small peripheral abscess, such as the case in diabetics, but when this is a controlled diabetic and the abscess is recently formed, short duration, and it is not causing urinary retention, in that scenario this patient can be managed by antibiotic therapy and a supportive care, what's called medical management. But if you have a large single cavity which is a peripheral in location, such as the one shown here, you can actually do a transrectal ultrasound guided aspiration of this cavity and that will be fine. For drainage of this abscess cavity, you have to put the probe in the rectum and through the needle carrier you advance this needle into the abscess cavity. The feeling of give way will tell you that you've gone in the cavity. You can actually monitor the abscess on transrectal ultrasound imaging. You can target the needle in this cavity and you can actually see the needle coming in the abscess cavity like here. And you can penetrate the needle up to the desired depth, withdraw the stellate and connect a 10 ml syringe to this needle. First, you should collect the sample for culture and sensitivity, which should be about 2 to 4 ml, and then you can aspirate the rest of the cavity. You can in real time by transurethral ultrasound monitor the complete emptying of the abscess cavity. Then if you think the pus is thick, you can connect betadine saline irrigation. You can actually instill that fluid in and you can see the cavity on truss actually increasing in size, and then you can aspirate the fluid back. So this is the way you can actually do some lavage of the abscess cavity. But when you have prostatic abscesses which are multicentric and then each abscess is having a different size and then each abscess, the fluid of the abscess is having variable density. So these are the characteristics of the abscess, and then such an abscess is giving rise to clinically refractory urinary retention, also toxemia and pain in the perineum, and sometimes we notice that controlling diabetes is becoming really very challenging. The pus in the prostate does not allow a good diabetic control, and good diabetic control, if not achieved, the abscess cannot be medically treated. So you get into a vicious cycle. When that is the same, you will be required to do a transurethral resection of the prostate. Now before you start thinking or doing a transurethral resection of this patient, you need to do something special here, and that is, first of all, you have to identify the extent and the distribution of various abscess pockets in the prostate gland by a CT scan See here, this picture is showing you that there are more abscess cavities towards the lower part of the prostate, that is towards the verumontanum. Another picture is showing you the abscess which is located more in the anterior part of the prostate, anterior to the urethra. So obviously if you have this information beforehand, and when you are doing resection at that point, you know that you are going to hit the abscess. In another patient, you see the entire prostate is almost replaced by abscess. A lot of cavity in the para-veru part and smaller cavity below the bladder neck. And in the another image, you can see that all around the urethral lumen there are multiple cavities of the abscess. So you know that you will find abscess everywhere. You should also try and see that is it that the entire gland is replaced by abscess, or you still have a BPH tissue somewhere, such as here. There is an abscess cavity just below the bladder neck, and you still have a lot of adenomatous tissue in the remaining gland. So you have to not only deal with abscess cavity here, but you will have to deal with the BPH part by dissection. Now, I am not trying to sell you that you should do a CT in every case to find this distribution and location of the abscess cavity. I am just trying to give you a concept that you need to have appropriate knowledge about the location and distribution of abscesses in the three-dimensional orientation. You need not do CT in every case. You can actually do a transrectal ultrasound, and you can do a transverse imaging first. See the left lobe by imaging, is there an abscess there, and then see the right lobe and try and locate where the abscesses, such as the one here. And the moment you see abscess, you should try and find out the echogenicity of the content. How much is the fluid like, how much is the organized abscess, because if you have more organized abscess, you have to actually use the loop to resect the abscess, to remove the abscess from the abscess cavity. So the transrectal ultrasound imaging is a really good option, and you can not only see the morphological details of the abscess cavity, but you can actually take dimensions of the abscess cavity in transverse section, in longitudinal section, and you can be in a position to know how much of the prostate abscess volume that you're going to handle in that particular case. So you can request your sonologist to give you this detail. When you are actually going to do the transurethral resection procedure, you may actually do what is called deroofing. The meaning is that you drain only the abscess, or else you can not only remove the abscess, the pus part in the cavity, but you can actually resect the walls of the abscess. And that's what the meaning of by dissection. So you can either do a deroofing procedure or you can do a resection procedure. How do you decide which one to do in which case? You do deroofing if you have abscess of this kind, a well localized abscess, and a single abscess, and the content is fluid. Now these abscesses are actually pre-existing prostatic cysts which got infected. But then if you are deroofing the abscess cavity and the pus is very thick and viscous, that is the kind of situation you can face. You resect it, you open the abscess cavity, and the pus is emerging from the holes slowly. It is actually forming something like snake in the lumen of the prostatic cavity. This is because the pus is so thick and the pus is so viscous. So if that is the case, how do you expect that the deroofing will be all that is required? So here you will go for making a bigger hole, and if the multiple abscesses are present and each abscess is of different size, and you expect the content to be viscous by transrectal ultrasound, and you see that the location of these abscess cavities is peripheral, you probably will have to do a regular transurethral resection and resect all abscess cavities. Here we are doing this procedure, and you have to first orient yourself by looking at veru montanum, the apical tissue, left lobe, and then this is the bladder neck, and this is the lumen of the bladder. You will appreciate that although this is a case of abscess, there is not much of hyperemia and edema on the prostate as a result of antibiotic therapy. So you begin resection, you know this patient has abscess in the left lobe. So as you cut one loop and you cut the second loop, the abscess starts welling out. And you just made a small hole in the abscess cavity. By the very speed of the flow, you know that the abscess is in tension. By the way the pus is flowing out, try and gain the information about viscosity. Now, if you think it is viscous, you have to make the size of the hole little larger so that the pus flows out properly. And then you have to have an idea where all the abscess may be spreading out, and you cut by the side of the hole so that the pus can easily flow out. What I am saying is that the size of a hole that you made on top of the abscess cavity should be actually with decapping kind of a thing. And then you enter the cavity, and if the pus is organized like here, you have to move the loop and make retrograde strokes, reverse strokes, to shave off the pus that is adhered to the wall of the abscess cavity. The intention is, by irrigation fluid, wash out all abscess cavity. This is very important. Don't leave it for the nature to take care of this later on. As a surgeon, remove all the pus, put it back into the bladder, and then drain the bladder, and that would be a good thing to do. The key question is, what do you do to the wall of the abscess cavity? When you have drained the abscess, now you focus at a point of the wall. Sometimes you see a very small pus popping out. Orient yourself to the anatomy by looking at veru again. This is veru montanum, and this is the cavity of the abscess cavity, the small hole that you made. You widen this hole first, okay, and now you are planning to go into the cavity lumen here, and widen the hole again, and let the scope go into the abscess cavity. As you go in the abscess cavity, you mop this abscess by the loop, shave off the entire pus that is adhered to the wall of the prostate cavity, and then you may notice a small teeny point from where the pus is coming. Just by the loop excursion, try to open the hole. If need be, small tip resection can be done. Move loop a couple of times, put pressure on the wall. By the pressure, you can squeeze the pus out. Okay. So, remove the granulation tissue also from the wall of the cavity, and as you move the loop, you will see few droplets of pus are coming out. If that is the case, small gentle resection is done, and then you notice more micro abscesses are coming out. What I am trying to say? I am trying to say that in the wall of this a large cavity, you can have small micro abscesses all around, and you have to think of removing these micro abscesses from the wall by doing focalized resection at different places. Don't resect the entire abscess wall, but mop up the abscess cavity and resect those micro abscesses so that a good drainage is properly done. Sometimes you can have an abscess by the side of veru montanum, and you want to push finger in the rectum, and you press. If you press, the pus comes out. The moment you release finger, the pus is sucked back in. And that's what is happening. Your finger in the rectum is pushing the pus out of the hole, but it is so viscous, the moment you release your finger, it goes back into the cavity. So here, if that is the case, you make a very small cut to make the hole wider, and then again do this digital evacuation. Now put pressure so the entire pus comes out, and when you are increasing the lower lip to make the hole bigger, look at the veru montanum again. And this is very vital. You can sometimes go down below the veru montanum and injure the sphincteric urethra and end up in incontinence later on. So here it is better to wait, put the pressure of the tip of the sheath from inside and finger from the rectum, both sides, to evacuate this abscess cavity. This pressure technique is better at this location rather than trying to go on widening the hole and then ending up in coming below the veru montanum and risking incontinence. So friends, if you look at the principles of transurethral resection for TURP for abscess, first of all, you have to decap the cavity. Decap means not a small hole, but remove a large top chunk, enter the cavity, clean well, resect peripheral walls to clear micro abscesses. You must keep controlling bleeders. Try not to open sinuses, and this is important here, because if you open a big sinus, the pus from the cavity will be going into sinus, and you know what it means. It can have severe bacteremia and septicemia. But then over the years I have seen that this pus in the prostate cavity is usually sterile, and you can actually go about doing proper resection, and there is not a very high incidence of post-operative bacteremia. When you have abscess around veru montanum, don't go on resecting it. Use digital electrical examination to put pressure and to evacuate the abscess cavity. Post-operatively, sure enough, you should be on the guard for septicemia. Give lower spectrum antibiotics. You can, in fact, you should explain the patient about slightly higher incidence of incontinence after the surgery, and you must also tell the patient about risk of secondary hemorrhage. You should also caution the patient about the risk of secondary hemorrhage, which is slightly higher in these patients. Why is the incontinence more? This is because if abscess is located by the side of veru montanum, it hampers sphincteric function by edema. And then there is edema in the fossa. So there is a higher degree of sensory urgency. So, but you should understand that as the inflammation will settle, as the abscess cavity will heal, whole thing will go. So you have to tell the patient probably this is 1 week misery after catheter removal that he will have in terms of incontinence. So friends, with the availability of better antibiotics and then improved technique of resection and understanding what all you can do with the resectoscope, and then finally a better perioperative care, it is feasible to do a safe transurethral resection for the abscess, and ultimately patient gets a very good outcome. Thank you very much.